Good afternoon. Thank you for giving me the opportunity to present our project about evaluation of brucellosis system in Palestine from 2014 to June 2015. Demographic of Palestine. On the map, the whole white area was used to be Palestine, but now it is occupied by Israel, and only the small green dots in the middle are called the West Bank, and the small coastal green area called the Gaza Strip. So Palestine consists only of West Bank and Gaza Strip now. The total population of West Bank and Gaza Strip is 4.7 million. 60% of them are living in the West Bank and 40% in Gaza Strip. The whole area of West Bank and Gaza Strip is about 6,000 kilometers square, most of them in the West Bank, and of the Palestinians, there is about 74% of them are living in urban areas, 17 in rural, and 9.3 in refugee camps. The national surveillance system in Palestine covers both West Bank and Gaza Strip. For brucellosis, it is a passive surveillance system, and brucellosis is a weekly notified disease that must be notified within 1 week after diagnosis. In the first graph is the incidence rate between 2008 to 2014, and you can see there is a sharp increase has started in 2013. The next graph is about the cumulative frequency of cases in 2015 and 2014. There are more than double the cases in 2015 than 2014. This is the flow chart of the surveillance system in Palestine. After disease onset, the patient may go to the public sector, the horizontal line, and after diagnosis at MOH hospitals and primary healthcare centers, primary health centers must notify the Central Preventive Medicine Department, which is responsible about the surveillance system in Palestine. However, some lab confirmation tests are not done in the primary health centers and done only on the central MOH lab, which also must notify the Central Preventive Medicine Department. In private sector and NGOs, there is a statutory duty that all hospitals, clinics, primary health center labs to notify the team, the MOH team, about all notifiable diseases. Why evaluating brucellosis surveillance system? It is the first one done in Palestine to identify areas that need improvement and to be a baseline for further evaluations. 3 attributes were chosen and evaluated. First one, 2 dimensions of completeness, case reporting and surveillance data. Second, timeliness, and third, representativeness. ACDC and WHO guidelines were used. We used WHO case definition of brucellosis and the capture-recapture method. We collected data from the 10th of June to 15th of July from all government, private NGOs, hospitals, primary centers, clinics, and labs, and in addition to Central Preventive Medicine Department in the West Bank only. We used the patient full name, date of birth, and place of residency per identification. The participation rate was 100% for governmental sector and 84% for private and NGOs. The results of the third dimension of completeness is for case reporting. As I mentioned, we use capture and recapture method, which is a common method for estimating the total numbers of cases by using more than one source of data. Here we have 2 sources of data. The first one is cases notified to Central Preventive Medicine Department, column 2. And the second source is cases diagnosed in private and NGOs, column 3. And after that, we identified the match cases in the two sources, column 4, and we found that about 68% of cases in private and NGOs are notified to Central Preventive Medicine Department in 2014, and only 44% in 2015. From the numbers in this table and using Chapman's formula, we found that the estimated total number of cases in 2014 is more than 500 cases, and in 2014, and in 2015 they are about 978 cases. According to this number, the sensitivity of our surveillance system is about 70% in 2014 and 45% in 2015. And the sensitivity of private and NGOs, 31% and 27% in 2014 and 2015. And after that, we calculated the incidence rate, and we found it is about 20 per 100,000, which is much higher than the one published by MOH, which was about 40 per 100,000. The second dimension of completeness is surveillance data. From the notification forms, we found that address and phone, occupation, and lab tests are the most variables with missed data, and they are more in 2015. For example, in 2015, 20% of data about address and phone are missed. For timeliness, we used this table, which is developed by WHO to compute the timeliness of reporting, and we found in 2014 that only 34% of cases are notified to Central Preventive Medicine Department, and in 2015 only 20%. After that, we decided to study the whole notification process. We defined time points and evaluated the timeliness of reporting. First, we studied from disease onset to notification to Central Preventive Medicine Department. Second, from disease onset to registration, and the third, from diagnosis to notification. From this graph of cumulative relative frequency, we found that the median day is 35 days, and it ranged up to 90 days, which is a long period, so we decided to go deeper and identify the factors contributing to this delay. We found some factors that we can't control related to the political situation in our country and financial crisis. However, some factors like disease onset and registration, also it is the main responsibility of patients themselves, but the MOH and the surveillance system can improve the awareness and education of patients and reduce this period. From disease diagnosis to notification, as I mentioned in the WHO table, only 27% of cases are notified within 7 days after diagnosis. Here, all patients need 49 days to be notified instead of 7 days. For representativeness, we compared the cases notified to Central Preventive Medicine Department with cases missed by the surveillance system in Palestine and detected by our study. We compared them by age, gender, and place of residency. We found there's no significant differences between them in gender, place of residency, and age. Our conclusion: the notification of labs in private sector and NGOs to Central Preventive Medicine Department is decreasing in 2015, which affects the sensitivity of surveillance system. Primary healthcare centers showed remarkable delay in reporting after diagnosis, and patients represent to their practitioner showed another delay. Not having 100% of key information of patients like address and phone, occupation will affect any response action. Our surveillance system showed representativeness in terms of age, gender, and place of residency. Recommendation: increase awareness among physicians about the importance of notifying disease in a timely manner and importance of having a complete filled out application. Study the possibility of introducing electronic reporting system and networking, promote public education about brucellosis and the importance of receiving an early management for patients, mandatory reporting from private and NGOs lab of brucellosis cases, revisit our surveillance objective and plans for eradicating brucellosis, periodic evaluation of brucellosis surveillance system. Thank you. Any question?
Thank you very much, Huda, for the presentation. Any questions?
Mike Catchpole, ECDC. Thank you very much. Very nice presentation, a good piece of work. I just had, on this slide about completeness, I did notice that in 2015 you indicated that you had much lower levels of completeness on laboratory data. And I wondered whether that meant that you didn't have laboratory confirmation for cases, and what that meant in terms of how confident you were about the validity of diagnoses in 2015, because clearly it's a dramatic rise, but one of the issues there would be whether there were more false positives if you didn't have laboratory data.
Here, our case definition, we use the WHO case definition about the confirmed cases, that it must be, what is used in my country is only AST test, and it must be 1 to 160. And all cases with this test is included in this study. Yes, we concentrate on this case definition.
So the missing laboratory data was other?
Others, yeah.
Okay.
No, the missed cases are cases of brucellosis, but the surveillance system, the national surveillance system didn't detect them. They are not notified to our system.
Okay.
And we detect them by our study because we contacted all the labs in the West Bank. And we compared the names by full name, date of birth, and place of residency to identify the match cases.
Okay, that's helpful. Thank you.
Okay.
Other question? So I have one.
Okay.
So, you know, brucellosis is a zoonosis. So what is the profile of brucellosis in animal in Palestine?
Sorry?
What is the profile of brucellosis in animal?
In animal?
Yes.
This is the problem in Palestine, is that most of the cases are from animals. You know, we have borders not controlled by the Palestinian, and many of the infected cases are coming from the other side, and we are the Palestinian, we are not controlling the borders. And many cases, the human cases, are from the animal cases. The environmental ministry in Palestine is trying to vaccinate this animal, but we still have this problem of shortages in resources and the financial crisis we have for vaccination.
Thank you very much, Huda.
Yeah.